So we have covered some of the contents of the abdomen in terms of like pelvic cavity and peritoneal abdominal cavity. We learned about these particular cavities and the reflections of this particular cavity, peritoneum. We call this as a modifications of the peritoneum, which can be classified in three content. We call them as these reflections, which are of like a greater and lesser omentum, of which has got like a importance related to their positions and the functions. Now, other than this, we have talked about some of the ligaments which are present in this particular presence in this particular abdomen. We call them as peritoneal ligaments. There are a number of ligaments. The importance of the ligaments we have talked about. They are important in a sense. They contain neurovascular structures. So whenever we are going to do any surgeries related to the abdomen, related to the organs, we have to deal with these peritoneal folds. So they have the blood vessels. Until we secure the blood vessels which are placed in it, we are going to be having a messy surgery. So we have to secure the ligaments or peritoneal ligaments like gastrosplenic or linorenal involving this particular ligaments. We are going to do surgeries and then we are going to perform the actual surgeries, or else it will be a trouble unless until it is secured, because all of them contains important structure in terms of like a blood vessels. Now, other than this, we have this particular folds of the peritoneum that we have mentioned here as well. In the abdomen, we have some folds. We call them as umbilical folds, median, medial and lateral, and some reflections of the abdominal fold present in the pelvic cavity. We call them as vesical folds, rectovesical, uterovesical. All these things are rectouterine pouch. These are the folds that is present in the pelvic cavity. So we will talk about this particular peritoneal folds that is present in the pelvic cavity. When again we come across this particular peritoneum or pelvic region, then we will again talk about this particular content, which is lying between like rectovesical pouch or rectouterine pouch, etc., etc. So moving from here, we are going to talk about the last phase of this particular or last segment of this particular peritoneum cavity. We call them as peritoneal cavity proper or parts of this peritoneal cavity. This is highly important content, and each of these segment may have large questions or small questions, and moreover, more importantly, it has got immense clinical importance. So explain why kind of questions are several times features based on this particular peritoneal cavity and the modifications of that. So to start with that, this abdominal cavity, which is maybe synonymously can be like denoted as peritoneal cavity. So once you open this abdominal cavity, that we have done in the dissection classes, once you split through this particular anti-abdominal wall, we enter to a space where we see all the organs and viscera are placed in. So that larger abdominal cavity is covered or wrapped around by this particular peritoneal fold, and that particular peritoneal fold or peritoneal membrane, we call them as parietal layer of peritoneum. So that particular parietal layer of the peritoneum, if you breach that, then you can see the organs lying deep to it. So that particular cavity, once you breach the peritoneal membrane, or that particular known as the parietal layer of peritoneal membrane, then we end up into a cavity. That cavity we call them as greater cavity or greater sac of the abdomen. So this particular greater sac is anything and everything which is present once you cut through this anti-abdominal wall and breach this particular parietal layer of the abdomen. So we parietal layer of peritoneum. So we have cut this particular anti-abdominal wall, cut through muscles, and then we have cut this particular parietal layer of peritoneum. Then we see this particular stomach, great intestine, walls of small intestine, etc., etc. And gradually we have removed some of these parts of it and exposed the greater part of the abdominal content or the organs and viscera, bloods, etc., etc. So that's how we have proceeded. So largely, when you start with, we have a great cavity or great space visible. We call them as greater sac. Now, as this particular disease of the abdomen are undergoing for exploration, we get across some of the more and more diseases. We explore this abdominal cavity more and more. So more and more we have exposed through the abdominal diseases and abdominal problems. We have exposed with some other hidden or deep pockets which are lying somewhere deeper in this abdominal cavity. So we have this particular abdominal cavity, we call them as Greater Sac to start with. And as we have discovered more and more abdominal diseases through surgical interventions or through cadaver dissections, we have found another space which is rather concealed or hidden other than this Greater Sac. So that cavity or this particular sac which is hidden or partly occupied this posterior side of this particular stomach, which is lying in between this particular stomach and the posterior abdominal wall, there is another cavity which is present in here. That particular cavity we call them as lesser sac. So these two cavities are broadly classified as two peritoneal cavities that we have in the abdomen. So we started with the cavity, we call them as Greater Sac. What is Greater Sac? Anything and everything is visible once you cut through this particular anteabdominal wall and the peritoneal. Within this particular Greater Sac, whatever the content we are seeing here is hidden here. Then we see that there is a complex or hidden concealed cavity present somewhere deeper or deeply lying place, which is lying behind the stomach, and it is concealed. That means we can normally do not see unless until some diseases pops up. Now how come this particular cavity becomes visible? We have an organ present in the posterior abdominal wall. We call them as posterior abdominal wall structures, we call them as retroperitoneal structure. One of the structure is present here, retroperitoneal, is pancreas. So with these diseases of the pancreas, we see that accumulations of the pancreatic infections or any kind of diseases that leads to secretions coming through this particular pelvic cavity or peritoneal cavity, and that is occupied behind this particular stomach and lying between the stomach and the pancreas and creating a encysted kind of cyst there. And if you explore this particular cyst, we see that there is kind of like lying behind, and there is a space we discovered them and we have named this particular space as lesser sac. But in a true sense, if you just like explore that, later with the exploration we have seen that this particular lesser sac is nothing but a squeezed and hidden sac which is continuous with this Greater Sac. So this Greater Sac is squeezed just like we are squeezing a balloon, and a part of the squeezed balloon is moving back and hidden on the posterior side. So this lesser sac is basically a squeezed concealed part of Greater Sac which is lying behind the stomach. So how come this particular thing squeezed over here? This because of the enlargement of this particular stomach and this particular organs and viscera and the liver. This particular Greater Sac is compressed, squeezed and squeezed and moved on the posterior side, and as it is lying hidden behind here, we name it with Greater Sac to lesser sac. So there are two sacs which are visible, one is Greater Sac, other is lesser sac. So these are the two content. What's wrong? Light. Where is light? You want a light there? This one. You want to put this thing on or off? Put off. On. Is it responding? এখানে হচ্ছে না? Okay. Is it okay with everybody? Okay? Alright. Okay. We'll take both of them. All or none law. So one, if you are looking for one is free. This one is free. ঠিক আছে থাক, অসুবিধা নেই আমার. Yeah, early for next class. So we are settled down to this particular abdominal cavity into two entities. One is Greater Sac, everything and anything, and lesser sac. Now let's talk about the lesser sac that we are referring to. So which is a hidden concealed sac which is lying behind this particular stomach. So this particular lesser sac to start with is an exam short note. We talk about this particular lesser sac, asking about this position, location and this particular lesser sac, how it is there. So this particular lesser sac is lying, it's a peritoneal space which is lying behind the liver, lesser omentum, stomach and upper part of this greater omentum into a closed space, a closed sac which is lying there, which is not visible once you open the abdomen. So this particular sac, which is a concealed sac which is lying behind the stomach. Now how we are going to see this particular place? We have to cut through this greater omentum, split here, because this thing is sealed. You see that this is having a lesser omentum lying between this particular liver and this lesser curvature of the stomach. So this is breached by this particular peritoneal membrane. We call them as lesser omentum. So it is covering anteriorly. Then we have this particular liver which is covering on top, and then we have this particular anteriorly, we have this particular stomach, then we have this greater omentum. On this side we have the spleen, and there is an end of the cavity there. So we do not have anything which is making this particular cavities open or visible to us. So only we can see this particular cavity if we cut here through this particular greater omentum or this lesser omentum, then we can go behind it, then we can see the space. So that's why we are saying that this particular space is a hidden space or concealed space. So to define this lesser sac, a definition of it, it's a peritoneal space. Of course, it's a kind of part of this particular abdominal peritoneal space lying behind the stomach and this lesser omentum and the liver, which is covering these things anteriorly, and this particular space which is lying over here do not have any communication from above on the left side or in the bottom side or inferiorly. So above, that means superiorly, and inferiorly it is concealed, and so it is sealed on this left side by the spleen. This has only one natural communication through this particular opening over here from this free margin of this place, which you call them as lesser omentum. So we have a natural communication through this particular lesser sac to the greater sac through this particular opening, which we call them as foramen of Winslow, also known as epiploic foramen. So this whole greater sac is communicated naturally with this lesser sac, which is a space of the peritoneum, which is lying behind the stomach, and this particular liver is communicating through this sac. Through this particular opening, we call this opening as epiploic foramen or foramen of Winslow. So what you have to know this, what do you mean by the lesser sac, and what is the natural communication that it has. So it is covered or kind of sealed in each and every aspect. So that means it's superiorly, inferiorly, and to the left side it do not have any communication. Only communication that is left with is this opening, that is the door that it has. We call them as epiploic foramen. The other name of the epiploic foramen is known as foramen of Winslow. Other name of that is known as omental foramen. This can be tested in examination giving all these three names. We have to remember all these three names, right? So these communication doorways that we have to focus in the next to it. So this is what we are talking about. So to make this particular space more to understand is more better. That's why seeing here greater omentum is cut. You have lifted this particular stomach, then you can see this particular space. That's what we are going to explore that during surgery. To do any procedure during this particular or happening in this pancreas or this particular lesser sac region. Or naturally we have an opening here. So once we have dissected the abdomen, everything intact, we can reach through this particular space which is lying hidden, concealed behind the stomach through this opening or the door. The door is over here. The name of the door is epiploic foramen. So what do you mean by the definition of epiploic foramen? It's a natural opening between the lesser sac and the greater sac. So through this opening, it is going through this particular space. We call them as lesser sac. Now, we have to know this boundary of this particular epiploic foramen. That means what lies above, what lies below, what lies anterior, and what lies posterior to it. So next picture is clarifying this particular boundaries of that opening which is communicating or foramen of Winslow. So boundaries of epiploic foramen or foramen Winslow. So what is above, what is below? So above is the liver, below is the first part of the duodenum. So this particular picture helps us to identify what is holding this upper limit of this opening and what is holding the lower limit of the opening. So opening is this one where you have put an arrow on it. So this opening is limited above by this particular lever, and on this lever we know by the lobes of the lever we have this chordate lobe present over here. So the chordate lobe with the C is lying above, which is holding this particular upper limit of this particular opening. Lower limit is this one, which is the first part of the duodenum. So this is stomach, this is having the body, and then we are settling down to this place. We call them as spirulus and this pyrolic canal. Then we have the beginning of the duodenum. So we have this first part of the duodenum holding at the bottom edge of here. So lower limit of this, inferiorly we have the first part of the duodenum. So this particular picture helps us to identify above and below limit of these foramen of Winslow, omental foramen, also known as epiploic foramen. Now this picture helps us to identify what is anterior and what is posterior. This is a sagittal cross section which is looking of the individual from above. So this is an individual which is cut through and you are looking from above. This is anterior side, this is posterior side, identified by the presence of the vertebra on the back side. Now this space we are talking here is that particular space, we call them as lesser space or lesser omentum or lesser sac, which is present in here. Now this is the stomach, the cavity of the stomach is visible. We have this particular lever which is present. This is on the side, right side, left side, kidney, and this is the big vessel, aorta and inferior vena cava. Now this particular thing which is hanging from this particular lesser curvature of the stomach to this particular lever, we call them as lesser omentum. So lesser omentum which has this margin, we call them as free margin of lesser omentum. So this free margin of the lesser omentum which is lying over here. So free edge of the lesser omentum present anteriorly, and behind posteriorly we have this blue line which is present over here, we call them as inferior vena cava. So the posterior limit of this particular opening, anteriorly it is limited by the free margin of lesser omentum which contains some structure that we have to know later on, will coming again, the free margin or free margin of lesser omentum. And posteriorly we have the inferior vena cava. So summarily together, superior, inferior, anterior, posterior limits of this foramen of Winslow, also known as this particular epiploic foramen or omental foramen, is very important, utmost important, because we do surgery in this plane. You're going to do surgery in the liver, you're going to do surgery in this gallbladder, you're going to do surgery in the pancreas, small intestine, large intestine, stomach, pylorus. We have number of cases coming over here for this CA or carcinoma of the stomach, gastric CA, or ulcers in this particular region. We call them spiralic ulcers. So we involve this surgery on this region. That's why this particular foramen have got importance, or rather very high importance. That's why we see that this particular area is anywhere and everywhere is tested in examination. Medicine, surgery, obstetrics, gynecology, any point, orthopedics, wherever you go, we have this particular thing known and coming again, because once you open the abdomen, you have to know this particular place, epiploic foramen, lesser sac, greater sac, and that's why we ask questions on it. So this particular entity, everything and anything is question. You cannot come to the examination without knowing the lesser sac, greater sac, and epiploic foramen, boundaries of the epiploic foramen, and this lesser omentum to be very specific, and free margin of lesser omentum, attached margin of the lesser omentum. I'll be coming on to this particular, emphasizing on this part. So this region has to be kept in mind. So this natural opening of this region, which is communicating with the greater sac and lesser sac, which is having a boundary above, below, anterior, posterior, that we have been known as foramen of Winslow, and also known as epiploic foramen, omental foramen. This has got immense importance over there. And significance of this greater omentum, lesser omentum, which is a part of greater omentum, squeezed posteriorly behind the stomach, liver, and this greater omentum and lesser omentum, which is placed in posterior side, which is present in here, which is having communications to it. Now, this particular space we are talking here is lesser sac or lesser sac or lesser sac cavity. So this particular lesser sac cavity have got like a little bit like a extensions. So that expansions or extensions, we call them as a recess. So this particular lesser sac, which is a cavity that we are seeing here behind the stomach, and posteriorly it is limited by this particular pancreas, we have some kind of extensions. One extension is above towards the liver side over here, this region where I am pointing here. We call them a superior recess of lesser sac. Downward extensions, which is going through this particular greater omentum towards this dropping down here, we have this particular cavity here and dropping down here, which is going down to its one. We call them as inferior recess. And to the lateral side where the spleen is there, it is little bit expanded. We call them as splenic recess. So above recess we call them as superior recess, which is expansion from this particular lesser sac. The below expansion towards this particular greater omentum, which is going here, we call them as inferior recess, and towards the spleen side we have little bit projected part, we call them as recess. They are not very enlarged spaces. This particular thing is little bit like a moving up. Now why this particular recess is important? Whenever you are exploring this particular lesser sac, these are the recesses, are the pockets where you have to dig more, because if you have pus accumulated into this particular space, into these recesses or pockets, they trying to get in. So you have to clear this particular recess, or else it will be incompletely evacuated. We'll be coming here what we are going to mean about this particular draining of the pus and nursing the patients as we are going through the clinical problem. Then we are going to talking about the research once again. So, before we move to the next content, this is one thing what you have to master here before. Lesser sac, what do you mean by lesser sac? Where exactly it is located, anteriorly and posteriorly, how this particular sac is lying. So, this is a sac which is lying behind this particular liver, stomach and this omentum. It's an enclosed space all together, only has a communication to the right side towards the greater sac. That communication we call them as epiploic foramen, and that particular epiploic foramen has a boundary anterior, posterior, above and below, that you have to know. And this particular space which is lying here have got little bit expansions, we call them as recess. They are above recess, below recess, and towards the left side splenic recess are there. So, this enclosed space is exam short note. We have to prepare this exam short note with the clinical importance to it. We will be coming to the clinical importance next to it. So, this is what we are talking about. Whenever you are going to approach this, this is the way naturally we are into it. So, all this thing which is you are seeing here is a cross sections of the human abdomen, and this particular cross section, sagittal cross section, you are seeing here in this region, everything in black is the greater sac cavity, and the lesser sac cavity is the grey shadow, and the grey shadow with the black shadow is communicating with this hole which has an arrow popping in. We call them as epiploic foramen or omental bursa, omental foramen, also known as foramen of Winslow. So, this is what we are trying to mean. So, if you are seeing from above sections, posterior, anterior, stomach, free margin of this lesser omentum, attached margins of the lesser omentum, and then we are approaching to the right side and going on the back side, and which is limited over here in this region by the spleen. So, everywhere in this particular space is enclosed above, below and this particular region, and it is communicating with the right side through the foramen. So, that is what we have to learn about lesser omentum. Now, from the lesser omentum or lesser sac, we are moving to the big sac which is known as the greater sac. That is all about whenever you are opening this. So, once you open this abdomen, this particular cavity is visible. That is the cavity of the abdomen. We call them as greater sac or greater omental bursa. The lesser sac also known as lesser omentum bursa, or in short omental bursa. So, this particular greater sac have got two compartments that we are going to talk about. So, once you have opened this abdomen, we probably have seen that this particular colon which is running. So, this particular colon which is covered here by this greater omentum, once you lift this particular colon, it is visible. So, this colon we call them as transverse colon, and then this particular transverse colon has a upward extensions like ascending colon, downward descending part, descending colon. This is how this particular cavity was placed. Along with that, we have this mesocolon running from the transverse colon, bridged with this greater sac, which is a greater omentum, and lying over here, greater mesocolon bridging with this greater omentum. So, this abdominal cavity can be divided into two parts by this placement of this transverse running structure or transverse colon. So, above this particular transverse colon, the greater sac cavity, we call them as supracolic compartment, above part. Supracolic, that means transverse colon. And then we have this below colon or infracolic compartment. Supracolic compartment, from the left to right, we have the spleen, then we have the stomach, then we have the liver placed in here. Infracolic, we have the coils of the small intestines which is present in here, the appendix and the cecum, and the ascending colon and descending colon which are present in here, and this particular thing is split into right compartment and left compartment by this oblique attachment of the mesentery or the mesentery. So, this particular infracolic part which holding this particular small intestines and ascending and descending colon is split obliquely by this attachment of this mesentery into right side and the left side upper. Now, what is the importance of having splitting into two compartments? With this particular sub compartment, that is, we have this in this region on this particular infracolic part, the infection spread can be limited. So, this infection spread can be limited from infracolic part to the supracolic part if it is occupying in the central part. Again, the infections on the right side can be limited to escape to the left side, can be limited by this attachment of this mesentery. So, this infection on the right side is kind of physically barriered to moving to the rest part of this. So, the mesentery attachments or these particular compartments that are present in the abdomen helps us to limit the infections within this great abdominal cavity. So, it limits this kind of infections in the abdominal region. Now, next to this side of this particular colon, we have a space. We call them as gutter space. So we have these right paracolic gutters and left paracolic gutters. Now these gutters are communicating with this particular supracolic compartment and infracolic compartment. If the infection spills over to this particular gutter space, it can freely communicate anywhere in the abdomen. It can run above, run below. Likewise, right side and left side. So these particular gutters, as we know these gutters, which are for the sewerage system. So these gutters plays an important role in case of the spread of infection from abdomen, infracolic to supracolic, or this abdomen to this thoracic or thoracic to abdomen content as well. So these communications or limits of the communications are achieved by this presence of these particular colic or subcolic or infracolic compartments. Now, as we have this particular compartment, we have this organ placed in this particular region. So, supracolic compartment have got some kind of spaces which is present or which needs special mentioning. One of the spaces we already have discussed. We are going to discuss the rest of the spaces which is present. So, this particular spaces that supracolic compartment has, we call them as recess, just like expansion we called about. So, this particular supracolic compartment have got some recess that is present. So, we call this, there are 4 such recesses or spaces that is present within this particular greater sac cavity in the supracolic compartment. 1, 2, 3 and 4 we are going to talk. So, we take one at a time. So, this particular space that we are limiting or going to talk here is about the space which is lying between this particular diaphragm above and the lever below. So, this particular space we call them as subphrenic space. So, the subphrenic space can be split into right side and the left side by this attachment of this falciform ligament. We have seen this falciform ligament splitting this particular lever physiologically, anatomically into right anatomical lobe larger and left anatomical lobe, and this falciform ligament has an upper attachment which attaches to the undersurface of diaphragm and it falls down to the anti-abdominal wall. It holds this particular thing, we call them as a round ligament of ovary, which is a neurological remnant. I am not going to talk about that. So, we hold this particular space which is lying under this phrenic or the diaphragm which is present right side and left side. So, right side subphrenic space and left side subphrenic space that we have over here. So, these particular spaces are prone to have pouches or infections. That is what we are talking about, the recesses that are important. So, if you for example see that we have an abdomen infection, we have a pus accumulation. Now, pus is a fluid which is accumulating, it could be mixed up with the blood, dead cells, debris, etc. etc. So, this particular pus can accumulate in this particular region, we call them as subphrenic space. So, if the pus is accumulated in this particular subphrenic space, we call them as subphrenic abscess or subphrenic empyema, right side and left side. Clear? So, this limit of this particular subsphenic space above is limited by this particular diaphragm, anteriorly is also by the diaphragm, domes of the right side and the left side. Inferiorly, it is limited by this particular lever on this inferior and this right side, and left side as well. This particular have this region, we call them as lever anteriorly, and spleen on the left side, which is limiting this left subphrenic space. And if you have infections over here, we call them as subphrenic abscess. Infections, we call them as infections in here. So, fluid can accumulate over here, creating a pus accumulation, we call them as subphrenic abscess. Now, here comes your explain why questions. You have a patient who has an accumulation into this particular space, we call them a subphrenic abscess, and complaining of pain over the shoulder region, and explain it why. So, why the patient who has an infection accumulation collection under this particular diaphragm, which is limited by the stomach below, liver below, which is known as subphrenic abscess, complaining of pain in the right shoulder. So, what could be your possible explanation for it? Alright, go ahead. Because of the cause of the referred pain. Segment supplied by C3, C4, C5 spinal nerves. Same segment is supplied by the scenic nerve. So, this undersurface of the, thank you. So, undersurface of the diaphragm, right side and left side, we know that it is supplied by this particular phrenic nerves. So, phrenic nerve pierces the diaphragm, serves this particular recurrent pores and supplies this undersurface of this diaphragm. So this particular peritoneum under to it is also supplied by the phrenic nerve sensory supply. So that's why if we have this accumulation, the phrenic nerve can get irritated, and that particular irritations of the phrenic nerve is often referred to this particular shoulder region, because the phrenic nerve has a root value of the C3, C4, C5, which is C4 predominant, which is coming from the cervical segment, and C4 domain of this dermatome supplied by the tip of the shoulders. So that's why this particular thing which is having any kind of irritation under the diaphragm, any accumulation, is referred to the tip of the shoulders. So this is how they explain why questions are need to be answered and accordingly dealt with. So explain why kind of thing which comes with the subphrenic abscess. So any collections, it could be pus, it could be blood which is irritating the diaphragm, or the diaphragm, peritoneal diaphragm under to it, which is supplying with the supraclavicular nerve C3, C4, and same segment origin with the phrenic nerve. That's why we have this particular referred pain reaching to this shoulder region. Moving to the next recess or space within this region, we call them as subhepatic recess. That means above the liver we call them as subphrenic, or which is limited above by this particular diaphragm, and below the liver we call them as subhepatic recess. We have right side and left side, which is having this subhepatic spaces. Again, they can be divided into two parts, anterior and posterior. So we call them as a right anterior subhepatic space, right posterior subhepatic space, left anterior subhepatic space, and left posterior subhepatic space. Out of these, the posterior hepatic spaces are of significance, which are clinically important. That's why we are going to emphasize them, the posterior spaces on the right side and left side under the liver. That means subhepatic space or recess, which is a part or continue or expansions of the greater sac, which is lying over here, is important. Now out of that, the left side space we already have talked about. So left side subhepatic space on the posterior domain, which is lying here, we call them posterior left subhepatic space, is known as lesser sac. We already have talked about. So that's why we keep on talking or keep on saying or emphasizing that basically this lesser sac is nothing but the greater sac, which is squeezed posteriorly, which is lying behind, hidden. That's why we give a name, but later on we discovered, oh, this is the same greater sac which is squeezed, but we didn't want to make these things change over there, so we kept this as a lesser sac. But basically lesser sac is an expansion or squeeze part which is moving back posteriorly. That's why we referred with this particular squeeze balloon picture in the beginning of this session. So this picture is indicating here. So this same thing was there. As it is squeezed moving back posteriorly, this becomes lesser sac. This is the greater sac we are dealing with, right? So this particular posterior subhepatic space on the left side, we call that this lesser sac, which is covers this particular thing. And then we are going to talk about this right posterior subhepatic space. Now right posterior subhepatic space that we are going to talk here. So which is more or less the last entity or last important entity. So right posterior subhepatic space has a special name. We call this space as hepatorenal pouch of Morrison. This is like a Englishman who discovered this particular space which is lying here in the posterior side, or hepatorenal space, which is present in this right side, and between the liver and the kidney it is placed. That's why it is known as hepatorenal pouch of Morrison. So we have to know the boundaries which is present in here, which is present. So this is again this particular side pictures of sagittal picture. You are looking from the sides on these individuals. We have to identify this anterior side which is present over here and the posterior side based on this. So this is the kidney on the back side which you're seeing here. So this is the spines or cut end of the spines of vertebrae which you're seeing here. So this is the kidney which is present, this is the liver in the front side, this is the costal cartilages which you're seeing here, anteabdominal wall present in here. So this above and anteriorly we see this, the lobes of the liver which is covering here on the sides below this liver. That's why we are talking here is subhepatic space. So this particular space is anteriorly and superiorly is limited by this particular expansions of the liver. Posteriorly and on the little bit on the posterior superior side we have this kidney, on top of kidney we have the suprarenal gland. So posteriorly and posterior superiorly we have the suprarenal gland and this right kidney which is limiting backside. Anteriorly we have this particular liver, so is superiorly. So this particular space is a limited thing which is having over here, limited by the liver anteriorly superiorly and posterior superiorly by this kidney and the suprarenal space. So then we are holding this particular space, we call them as hepatorenal recess, so which is going into it and blinding in the end pouch. You look at this, the lower limit over here is continuous below. So, this particular space which is continuous below compared to this particular opposite side that we have, the lower limit of the lesser sac is breached. So, the lower limit is concealed by the presence of the duodenum. So, if you look back to this particular opposite counterpart space on the left side that we are going to talk here is the lesser sac or lesser omentum. The lower limit of this particular space is limited by this particular duodenum and also small intestine. Whereas this large right side, above you have the liver, below you have the kidney, then it is downwards communicating. So, infections can pretty much easily can reach to this particular hepatorenal pouch of Morrison from below, climbing from above. So, this particular region is very important. That is why clinically we see more and more number cases coming as the abscess communication or abscess collection in the hepatorenal pouch of Morrison, and that has got clinical importance that we are going to talk about. So, this particular hepatorenal recess again very important short note, we see that with the clinical importance to it. So, this particular space is kind of boundary we have to know. Then we are left with two other recesses in this particular region which is present in the infracolic compartment. We call them as gutters. We call them as paracolic gutters by the side of the ascending colon and the descending colon. So, we call them as right paracolic gutter and the left paracolic gutters. So, they are present on the right side between the body cavity flank and this colons, right side and the left side. And this gutters, as we have seen, this has a communication from the infracolic part to the supracolic part. So, infection from here, if it reach to the gutters, it can climb out or can drop down to this particular infracolic to supracolic, either way, vice versa. So, this colic gutters which is having presence in here, having a communication, especially the right paracolic gutters which is present here has a communications of the right posterior subhepatic space or hepatorenal pouch of Morrison. So, if you have infection, the abscess, say for example, it started with the right side paracolic infection. Say for example, you have an appendix infection or cecum infection which has burst open and pus accumulation has happened, patient is not treated. The infection reached to this particular right paracolic gutter right way as it is lying on that particular part, moves up, climbs up and creates a pus under the liver, and we call them as subhepatic abscess. We call them as a right hepatic subhepatic abscess or hepatorenal pouch of Morrison abscess. So, this brings us with a clinical problem that we are going to deal with. So, infections of the peritoneum, we call them as peritonitis. So, if you have the infections that attracts this particular defense quality of it is having kind of Cooper cells or defense cell that is present largely coming over here. The peritoneum is a live structure that is capable of secreting fluids. We call them as peritoneal fluids. So, fluid and the dead cells and this particular excess exudes or the kind of like a tissue fluids that comes here, could be blood coming over here, creates this particular pus inside the abdomen. If you have pus accumulation inside the abdomen, we call them as, which is communicating over there, that can accumulate in any space. Now, what you have to know, if we have the peritoneum, that particular flow of the peritoneal fluid, that we have to understand here before we move to the clinical problems. Now, as I have said, this peritoneum is secreting the fluid, we call them as peritoneal fluid, that is normally exhibited out. As it is secreted from this peritoneum, it is absorbed somewhere. So, this particular peritoneal fluid is liberated by this peritoneum, drops into this particular greater sac, lesser sac, and this particular peritoneal fluid has a flow of direction. That means fluids reaches from this particular abdominal cavity, pelvic cavity and climbs up through the paracolic gutters and goes under the diaphragm, and under the diaphragm it naturally gets absorbed. So, the normal flow of this peritoneum is towards this particular diaphragm and it normally gets under the diaphragm and gets absorbed. So, whatever the excess peritoneal fluid is there, the blood vessels which is present under to these particular regions, they absorbs it. That is a normal flow. Now, if you have a diseased person, that means it has an infection, that means you have increased productions of this fluid, we have increased pus formations which is happening here. So, if you let this particular normal flow go towards this particular diaphragm, this fluid as it is going up, climbing up, naturally drops down or settles down to this particular recess that we have just mentioned, subhepatic, subphrenic spaces, and can accumulate there, create the pus, and it is very difficult to drain those things. So that's why in a kind of sick patient, we try to settle down this particular thing in as much as possible. So whenever we have these particular patients who have these things, we try to slow down this particular upward movement of the peritoneal fluid by keeping this particular person like this, like 45-degree in inclined sitting position. We nurse the patient, we ask the patient to sit down in this posture. We do not allow to lie down like this. What happens if the patient lie down? We have this particular lowest most position in the pelvic cavity and this particular hepatorenal pouch. So if you lies down, the flow of the fluid naturally goes towards this particular headwards direction, and the pus and the fluid settles down over here. And once this particular fluid is thick, settles down, it creates this abscess, and once we have the abscess, it is impossible to drain naturally unless until you drain it out. That means you have to wipe these things, clean these things out. So whenever you have this particular pelvic infections, abdominal infections, we ask the patient to be in this particular posture. And this is your explain why kind of question. So why this patient have got infections, or post-surgical patients are nursed or given the treatment posture which is the supine recumbent position, 45-degree angle, and you have to explain why. 2 years back this question came, 0% answer rate was there despite telling in the class, because you are not there in a class, you are somewhere else, maybe partying somewhere mentally. So this is normal flow, that what you are mentioning here, and what happens in if you have these infections and how this particular thing, accumulation of pus tends down over here. So what's the advantage of keeping this particular person over here? Instead of this particular pus accumulation under this lever or under this diaphragm, we keep this particular pus low in the pelvic cavity. So you settle down the pus in one place and easy to drain through this particular pelvic cavity. So that's why we try these particular patients over here. Well, it's not like we are eliminating any chance of pus formation in the abdomen by this position, but rather we are cutting it down. So whenever you are losing the war, you have to make a deal. So this is the deal that you have. So once you have done that, infections cannot be limited. You have a pus formation, you just do not spread out the pus. We just try to make a deal, like limit it by keeping this particular pus in a one position. If you ask the patient to lie down, it will spread to many positions, under the diaphragm, under the liver, everywhere it will be pus. So this is the deal in the case of lost war. So we have no other options. You limit these infections to one position and treat that one position rather than treating everywhere and unsuccessfully dealing that. So this is what that we have to keep in mind. Rather than dressing in many spots, we keep this particular thing in a lower or pelvic spot where you can do this. Now, infections of this pelvis or infections of this peritoneum. How this particular peritoneum can get infected? It can get infected from the diseased gallbladder. It can get infected from diseased pancreas. It can get infected from the diseased appendix. That's what we have, these particular diseases which is sporing through or spilling through these particular regions. So we have the infections coming through the anteabdominal wall as well. We have the cut in the anteabdominal wall, stab injury. We have these particular infections entering to the abdominal cavity. That's how this infection getting inside the abdominal cavity. We have infections in the lungs, and that leading to the formation of pus in the lungs. We call them as empyema. That infections in the lungs can go through, penetrate through this particular diaphragm, can reach to this particular abdominal cavity through this peritoneum and can spread. So this is how this infection comes. Now, in case of the female subjects, we have an extra problem. What problem we have? It has this pelvic cavity or the peritoneal cavity is open to exterior naturally through the uterine tubes. The birth tract is communicated with this particular region. We call them as fallopian tubes. The fallopian tube has an opening end through this abdominal cavity. So the infections in the female subjects are more commonly encountered with the pelvic infections because of the natural defenseless condition for the birth tract, which is open, and that is what is you explain why. So why the female subjects are more prone to have pelvic infections or peritoneal infections. So this is what we have to explain. So spread of infections, that is what it is going on through these particular postures or through these particular problems. This thing we already have talked here. Any problem under this particular peritoneal diaphragm can be referred to the tip of the shoulder that we have already agreed, and we have to explain it why. And other than this particular peritonitis, we have the blood accumulations in this particular peritoneal cavity, we call them as hemoperitoneum. We have this air getting inside here, we call them as pneumoperitoneum. We have the excess fluid with this particular pelvic cavity, peritoneal cavity, or this particular greater sac, we call this as ascites. So we have the excess fluid within this, we call them as ascites. How does it look like? It looks like this. So we have this peritoneum, which is really secreting lot and lot fluid, and which is not absorbed. This is a kind of sterile clear fluid, and this particular abdomen looks like this, huge accumulation of the peritoneal fluid, we call them ascites. If we have them, we can drain them. We call this draining process as paracentesis. We put a needle on the side or the midline and drain these things out. So this is what we are experiencing with this particular problem of this peritoneum, or diseases of the peritoneum, or clinical problem. And local abscess formation, that we have mentioned several times, subphrenic abscess, subhepatic abscess, how they are getting in this particular region, we already explained that one. Now we are going to the last end, or not the least end of here, which needs a special emphasis on there. We call them as free margin of lesser omentum. Now you see that this is very important thing, rather very thing which we often forget. So this is what we are important to us, is that we have to know this. What do you mean by the lesser omentum? It's a peritoneal fold which is existing between the lesser curvature of the stomach and this liver under to it. So it is a communication that we are seeing here. This particular part, we call them as lesser omentum, has two parts as we have described. One part is falling from the liver to this lesser omentum, lesser curvature of the stomach. We call them as hepatogastric part. Other part which is coming over here, falling from this particular liver and ending on the duodenum first part, we call them as hepatogastric part of lesser omentum. So this particular hepatogastric part and hepatoduodenal part, they can be surgically defined as two parts. We call them as attached margin of the lesser omentum, which is attached on the lesser curvature this side, and free margin of lesser omentum, which is this part which is falling on the duodenum. Now you see that this particular part, which is known as free margin of duodenum, free margin of lesser omentum, holds a vascular structure. So you have a blue, we have a red, and we have a green structure covered or encased within this. So this structure is nothing but the structure which is going on the portal tract, or going through this particular the portal opening of the liver. So this structure that is having over here is a portal vein, and this is one which is known as the hepatic artery, and this is one is known as the bile duct. So these three structure is holding within this particular lesser omentum free margin. Whenever you are going to do any surgery related to this particular region, we have to secure this, or else it will be a severely botchy surgery. So that's why this particular omentum has got free margin and attached margin. We call them as, in anatomically we call them as hepatogastric part and hepatoduodenal part. The hepatoduodenal part, which is having free margin, we call them as free margin of lesser omentum, which holds these three structures. If through this, we are seeing here the green one, red one, and the blue one. The same thing we are seeing here, anterior to posterior. Whenever you're going to do the surgery, you have to be mindful. Again, the free margin is where you are going to see this particular foramen of Winslow or epiploic foramen. Behind here, you are going through. So between this particular free margin and posteriorly by inferior vena cava, we are entering through this opening. We call them as the foramen of Winslow or omentum foramen. We forget about this particular foramen and forget about this particular lesser omentum and the content of it, and that's why this is given several times in examinations. Why? Because they know that we forget? No, because this is what is important, or it is matters. Whenever you are going to do any surgery, in the supracolic part, you have to deal with this. That's why this knowledge of this part is utmost important. You cannot come to the surgery, or you cannot come to the open abdomen with this without knowledge of this particular free margin and attached margins of the omentum, also known as the gastrocolic part, hepatogastric part and hepatoduodenal part. So this is all about this particular peritoneum and this content of the peritoneum and lesser sac, which you have mentioned here, is exam short note, recess of it, opening of this lesser sac, which normally present, greater sac, recess of the greater sac, the greater subdivisions, subphrenic and subhepatic recess, and communications through it, and the spread of the communications, and explain why the spread of communications is limited by these attachments of these things, and how this particular spread goes here, what is the principle of dealing of these infections if you have infections in a recumbent supine positions, what's the utility or use of it, that's what you have to explain, understand and narrate it properly during examination. This is a region where you see a very high number of explain why questions are coming other than this particular natural this description of this part. So prepare this part very well.